welcome to another installment of ISTH Congress Daily News. My name is Cy Wilkins. I'm a clinical assistant member on the hematology service at Memorial Sloan Kettering Cancer Center and at Weill Cornell Medical College in New York City. Today, I am joined by Dr. Jeannie Callum. Dr. Callum is a transfusion medicine specialist and hematologist at Kingston Health Science Center and also a dual professor of medicine and professor of pathology and molecular medicine at Queen's University in Kingston, Canada. Today, we will be discussing the highlights of Dr. Callum's abstract titled Superior Efficacy and Reduce Transfusion with 4F PCC versus Plasma in Cardiac Surgery, the FAIR study. Dr. Callum, welcome.
Thanks very much for highlighting our abstract.
Okay. I'd like to start by asking about the FAIR study and how and your projects linked to the FAIR study.
Yeah, so over the last decade, we've been really trying to figure out what is the best recipe to stop bleeding after cardiac surgery. Cardiac surgery is related to multiple different hemostatic derangements. You have thrombocytopenia, platelet dysfunction, reduced thrombin generation, and hypofibrinogenemia. And so we've been trying to figure out what's the best recipe, what's the fastest, what's the easiest, what's associated with the best outcomes, so that across the world we can deploy better bleeding management for patients with cardiac surgery. And so we've been on this kind of journey trying to figure out, first we figured out, okay, you needed to use point of care viscoelastic testing to reduce major bleeding in cardiac surgery. And then we did a large randomized controlled trial in 800 patients comparing patients to cryoprecipitate versus fibrinogen to figure out that fibrinogen concentrate was the optimal therapy for patients with hypofibrinogenemia after cardiac surgery. So this was the next logical study that we needed to do, which was to figure out, okay, when you're faced with coagulopathy after cardiac surgery, you have ongoing bleeding. We have two products that are available. We have plasma and we've got prothrombin complex concentrates. And really, prothrombin complex concentrates, that's like what's routine in Europe. And then in the kind of the North American standard would be plasma. And so we really wanted to know, okay, there are two options. What's the best one for the patients?
That was the aim, the purpose of your project was to figure out, which is, more efficacious. Were there additional aims of your project?
Yeah, so we wanted to look at, obviously, first efficacy. Was it at least as good or better than plasma? The second thing we wanted to understand was what were the safety outcome? What was the safety differences? Obviously, if it stopped bleeding faster but caused more thromboembolic complications or more kidney failure, that's not a good option. So we wanted it efficacious and we wanted it safe. We also want it fast. And so obviously, the next thing we want to know is what's the impact on the cost of care? So there's lots of different things when you're evaluating different therapies that we really want to understand. So the FAIRS-2 study was to try and answer that question.
How did you answer this question in this project?
Okay, so we conducted a multi-center, multi-country, randomized controlled trial involving 12 cardiac centers across North America, across Canada and the United States. And we randomized cardiac surgery patients that were post-cardiopulmonary bypass, who had significant bleeding, had coagulopathy as defined by whatever viscoelastic testing or point of care testing that was used within the operating room. In addition, we added an additional safety check. We used a point of care device called a hemocron to check to make sure that the INR was elevated, because we didn't want people included in the study that weren't likely to benefit and could possibly have harm from participating in the trial. And we randomized them to one of the two therapies. So they either got, in general, 4 units of plasma, which is about a liter of plasma, compared to 2,000 of PCC.
Okay.
2,000 of 4-factor PCC. Mm-hmm. Patients could have one additional dose of that randomized product before they could cross over. and
Okay.
have the alternative therapy. We didn't want patients getting more than a maximum of 50 IU per kilo of prothrombin complex concentrate, just because there isn't a lot of safety data on very large doses of PCC. And then we monitored for our primary endpoint was hemostatic effectiveness, and that was defined as from an hour from the start of treatment to 24 hours after. Nothing hemostatic or surgical had to be done to the patient to stop bleeding. This was really the last thing. And then the patient was stopped bleeding, went to the coronary intensive care unit for post-op management. And those things included, needing a platelet transfusion, needing recombinant factor 7A for rescue hemostatic therapy, needing the chest cracked open, the chest left open because there was just too much bleeding to close it. So all those bad things that are kind of markers of continued bleeding after cardiac surgery. In addition to measuring the safety outcomes, serious adverse events, acute kidney injury, laboratory outcomes like the number of units transfused, INRs, chest tube output, all the kind of classical things that we measure in a cardiac surgery population.
Okay, excellent. So you had safety outcomes, but also efficacy outcomes, correct?
Correct.
Okay. And so what were the, basic results here that you'd like to highlight?
Yeah. So what we found was 4-factor PCC was more efficacious.
Okay.
We saw 18% absolute reduction in failure for hemostasis for our primary outcome. That was consistent across every subgroup of patients. So it was just as effective whether you were male versus female, long pump run, short pump run. It was efficacious across all patients enrolled in the trial. We also saw a statistically significant reduction in the composites of that primary outcome, things like, your, additional transfusions, return to the operating room, etc. We saw a major reduction right across all of those composites of the primary outcome. We saw a statistically significant reduction in blood loss by about 250 mils, which is about the equivalent of one red cell. We saw a reduction of about one red cell per patient. Obviously, a lot less plasma exposure because patients got 4-factor PCC instead of plasma. And in terms of rescue use in that first 1 hour to 24 hours after for recombinant factor 7A, there were no patients in the patients getting 4-factor PCC. So it would be very uncommon with 4-factor PCC to need rescue use of recombinant factor 7A compared to we had 9 patients or 4.3% in the plasma group. And so really across the board, the primary outcome and all the other bleeding outcomes, the transfusion outcomes, the chest tube output, we saw that 4-factor PCC was more efficacious than plasma.
So, as a clinician, based on these results, how would this change your day-to-day management of your patients?
Because in addition to better efficacy that we saw in terms of controlling bleeding, we actually also saw a significant reduction in serious adverse events and a 50% reduction in acute renal failure, which is really interesting when you think about it, because you've got one group that on average got 4 more units of plasma.
Mm-hmm.
So they got a lot more fluid that should have diluted their creatinine, increased their urine output. So they
Yeah.
should have had less acute kidney injury, but they
Yeah.
actually had much more.
Yeah.
And so because we see better efficacy, we were able to provide that therapy 25 minutes faster because it's small volume versus large volume. So it's just easier to get it into the patient. And we saw less adverse events. I think there's no question that this is a kind of game changer for cardiac surgery in terms of improving patient important outcomes. And there was absolutely no safety flag that 4-factor PCC increased the risk of thromboembolic complications or any other complication. It was completely the opposite. The safety measures showed that 4-factor PCC is better, faster, easier for the clinical team.
Okay. And do you see any financial concerns when it comes to hospitals switching to primarily four-factor PCC?
We're conducting an economic analysis comparing the cost of care for the two arms, including everything, the cost of the blood products, the cost of the hospitalization, the cost of all those extra serious adverse events and kidney injury, to look at what is the difference in costs. Because the patients in the plasma group got just so many more blood products and a lot more recombinant factor 7A, I think I'm pretty confident to say that that economic analysis is likely to show that four-factor PCC might be cheaper than plasma. Even though you're upfront loading the costs, you have less downstream costs. And so
Okay.
I think it's going to be hard to argue when you have, you know, um, better efficacy, better safety. It's easier for the clinical team. And I think our quality of life as clinicians, like that's important too, when we can do something that's a lot easier than some other strategy. Um, so we were able to give it faster, get the patients to the ICU faster, um, and with less serious adverse events and a kidney injury. Even if it was slightly more expensive, that's definitely worth the cost.
Okay, and with that, Dr. Callum, I'd like to thank you for taking the time out to give us the highlights of this, wonderful project that you've conducted. And I'd also like to thank the audience for tuning in again, and I'll see you later.
Thanks very much for having ISTH highlight this abstract. We're really thankful.